So our topic for this next session is payment reform, innovative payment schemes, and the take-up by healthcare systems around the world. And this, as Michael said earlier, is a huge, huge topic now in the United States as we transition from what has been the bedrock of our system, which has been fee-for-service, to something very, very different. And as we all know, fee-for-service has been long recognized for its volume-inducing care in different, quality in different aspects. And of course, we will know this goes back at least to George Bernard Shaw, who remarked in his preface to The Doctor's Dilemma that any sane nation should give a surgeon a pecuniary interest in cutting off your leg is enough to make one despair of political humanity. So we noted in our country back in the 1930s, a famous Hoover-era commission was formed called the Commission on the Cost of Healthcare, and it clearly identified fee-for-service as being one of the drivers of the high cost of U.S. healthcare at that time in the 1930s. So, of course, we have rushed into payment reform. That is to say, we've just now gotten started recognizing the utility of doing something very different. Maybe we've been stuck in what Michael would have called the catatonic era for the last 60 or so years. But as Winston Churchill said so memorably, Americans always do the right thing after having exhausted all the other alternatives. Our Institute of Medicine noted back in 2001 that the U.S. healthcare system was, for well-insured individuals, about the finest system to be found worldwide. It just wasn't as safe as it could be. We still have 40 wrong-site surgeries a week in the United States. It's not as effective as it could be. It's not as patient-centered as it could be. Care is not as delivered in as timely a way as it could be. It's not as efficient as it should be, and it's not as equitable as it should be. We have enormous numbers still of racial and ethnic disparities. Other than all of that, we have a really fine system. But so we are now trying to use payment in particular, whether it's capitation or other forms of payment, to push this delivery system change and to pay for better quality. And as we know, and as we heard earlier today, these are similar goals that we share with you here in the UK, to improve population health, to push care out of hospitals, to improve the quality of care, and really to achieve Don Berwick's famous triple aim. So with that, let me invite our panel up to sit up here on the stage, and we're going to hear from them in sequence. Each has been asked to offer a few introductory remarks, and then we will have hopefully a vivid, vivacious discussion thereafter. So let me introduce them now. First of all, we will be hearing from Dr. William Golden, who's the Medical Director for Health Policy in Arkansas. He is also a professor of medicine and public health at the University of Arkansas for Medical Sciences. Before his current position, he served as the Vice President for Clinical Quality Improvement of the Arkansas Foundation for Medical Care, and he's designed numerous statewide quality improvement and health technology projects. All of these people have very extensive, laudable bios. I do commend them to you, but in the interest of time, we will just highlight a few points. We will also hear from Stefan Hainer, who's Director of Healthcare Systems and Services at McKinsey in the company's Dusseldorf office. He's the leader of the German payer practice and co-leader of the EMEA payer practice, and has worked on studies in the pharma and healthcare sectors serving healthcare insurers and providers. We're also delighted to have with us Ben Richardson, who's a principal of healthcare systems and services at McKinsey, where he leads integrated care work in Europe, the Middle East, and Africa. He's based in London, but he works in the UK as well as in the US, Australia, and Africa. And in Africa, his work focuses on improving the effectiveness of health systems to deliver improved outcomes. So we hope he will tell us some about that. And also, substituting for Elisa Tarazona, we're happy to have Santiago Delgado, who's the Deputy Director of Ribera Salud Grupo. He has previously held the position of Deputy Managing Director at the Hospital del Vinalopó and Marketing Manager at the Hospital de la Ribera in Spain. So we're delighted that he'll be with us as well. So with that, let me turn things over. First of all, I guess we'll start with you, Bill Golden. That's, okay. Other way. Ben Richardson. Good. Thank you.
Delighted to be here this morning. I'm going to just give a quick overview of some of the things that we're seeing in payment innovation from around the world. And I think the main point I want to make is that we think that changing how we pay for healthcare can be the key to unlocking innovation. I think the previous speaker gave us the perfect setup for talking about this, that payment innovation provides a way to align payers and multiple providers behind the triple aim of improved quality, better experience, and reduced cost. It can do this by targeting specific levers of making value-conscious choices, reducing needless variation, targeting resources where they're most needed, and changing patient behavior. There are, broadly speaking, 3 different ways that payment innovation is being put in place through capitation, episodes, and pay for value, and multiple different ways that those are being put into place. But we think that there's good evidence of examples that have had sustained impact from payment innovation, although we also recognize that payment innovation on its own isn't enough. There need to be other enablers, and I think it's time for us to think about really seriously about how we put this in place in the UK. So just briefly on the 4 levers that payment innovation can support. The first is making value-conscious choices about clinical practice, so we can treat conditions in the primary care setting instead of the hospital, around decisions about procedures, what products we use, promoting generics, and what providers we use. It can do that by allowing providers to benefit from reducing costs by making these value-conscious choices. The second lever is reducing unwarranted variation, and so how can we understand what normal looks like and then consequently peer review what looks abnormal? By sharing upside for better performance and or improvement can encourage the right sort of behavior, and by providing a downside for poor performance can discourage the wrong sort. The third lever is better management of chronic condition, which can include more coordinated care, faster response to emergent conditions, and proactively managing condition. Can do that. Payment can support this with funding additional care and by allowing providers to benefit by reducing the total cost. And then finally, probably the hardest, is changing patient behavior to support healthier lifestyles, diet, exercise, etc. Incentivizing individual behavior and providing personal budgets may be a way payment innovation can support that. Just a couple pieces of data to support this. This is an example of unwarranted variation here in the UK. It's drawn from practice level data in northwest London. And what it shows is after normalizing for IMD, we see massive variation in every type of activity. What you see there is non-elective, elective, outpatient, and A&E activity. Every single one of them has a variation of about 2.7 from bottom decile to top decile. Closing the gap to median or top quartile would be worth between 11 and 22% for the UK, or between 11 and 22 billion pounds. Second point of data, thinking about where cost sits. It sits in a concentration around patients. So we all have heard 20% of the patients drive 80% of the cost. By creating a data set that matches at the patient level all health and social care data in Northwest London, we can demonstrate it conclusively here. You can see, the most shocking thing is not that the top 3 strata represent 80%, which people have sort of expected, but that if you look at the cost of the very highest risk is nearly £40,000, including health and social care, against an average of £1,200. And for half the population, they're only consuming £300 of healthcare per year. So it's just a staggering difference. And so we need to think about how can we target the resources in the right place, and how can payment innovation support both that targeting and also allow providers to benefit from investing in order to save against those areas. There are 3 major models that are being used, if we look internationally, that are progressively more aligned of payment outcomes. So at the bottom there is payment for performance. So that's paying bonuses for quality and increasingly for value. The second is episodes. So how can we bundle payments? And so not just have the hospital get paid for everything that comes through the door, but bundle up all the pre-op and post-op and any readmissions together so that they're accountable for that, and also consider not just the hospital costs, but costs in the community. Bill Golden will talk more about that. And then the third one is population-based payment or capitation, which can be used for incentivizing an entire system for supporting primary prevention for the healthy and the management of the chronically ill. When you think about how systems turn to put those payment mechanisms in place, you see different models of how payers and providers are doing it. So starting at the bottom again, with gain sharing and the pay-for-performance sort of mechanisms, you see pay-for-value schemes, for instance, Blue Cross in Massachusetts, and the alternative quality contract where they gain share any beating of the trend. So they know what medical trend looks like. They say if you have lower than trend, then we'll share that. Bundesknappschaft put in place a similar sort of approach. In the middle there, you see risk sharing, which could be episodes of care, and how do you then have a provider that takes on the risk around that episode and is accountable for it. You also see not just single episodes, but accountable care organizations. For instance, in California, the Hill Physician Group working with Catholic and CalPERS in order to create accountability for the whole system, but they still weren't taking full risk yet. It was aligning the direction and allowing for sharing of value aligned with outcomes, but not taking full risk. Full risk is taken by Ribera Salud, which we'll hear from later, and also Geisinger, Kaiser Permanente, ChenMed, and those are provider systems that take a capitation, and it's up to them to manage, just as we were just hearing about. There are also examples of how payers are trying to pursue that, and a couple of payers in the US have recently acquired hospital systems and physician networks so that they can completely integrate the system. Just a few quick observations, which I won't go through comprehensively, but from this huge explosion of payment innovation in the States, some common themes have formed. One of them, perhaps most controversially, is that payment innovation really needs to be at scale. Our colleagues in the States believe it needs to be at least 50% of payment channeled through these innovative models. At most in the UK, we're experimenting with a couple percentage points, so that's just a massive, massive change we're talking about. And that also it needs to be stable. We can't put something in place for a year and expect it's going to change overnight. Providers need at least 5 years in order to change their business systems and training and IT, et cetera, to respond to that. Those are just 2 points I'll pick out. Question is then asked, have we actually seen impact? And there are lots of studies that say, well, we're not really sure. We think if you look hard and find examples that have really done everything that's needed, there are good examples of sustained impact. Ribera Salud delivers 25% lower cost per head with fewer admissions and very high patient satisfaction. Bundesknappschaft has been operating for more than a decade, delivering 13% lower cost per head than control group. Kaiser Permanente, we know, delivers amongst the best outcomes in the country with below median costs. And ChenMed is a fast-growing provider that takes risk on a senior population and delivers lower admissions, lower readmissions with fantastic customer satisfaction. Now, these organizations don't do it purely from payment innovation. There are other things you need to do. And this chart just identifies some of the other things, including thinking about the patients and how we manage them, having innovative delivery models, supporting the innovative payment with information flow and IT systems, having new models of accountability and governance, developing clinical leaders, and a culture that supports this type of behavior, which is different than the type of care many people were trained in, and partnering with patients. And every single one of these systems pursues all of these things. And I think increasingly it's becoming clear that you need to think about the questions you want to answer in setting up systems like this in this order. So who are we going to focus on? How are we going to deliver them that care? How will innovation in payment support that? What information flow do we need to have? What changes in government? What changes in clinical leadership? What changes in how we work with patients? Finally, how might we think about taking this forward in the UK? We could think about change at multiple levels. At the system level, I think one of the most exciting examples I've seen is what the CMS and Don Berwick's CMMI put in place in the state innovation model, which has unleashed just a massive amount of change. by calling for 5 at-scale testing grants and 25 planning ones, with nearly $500 million of resource, and it's catalyzed the entire country in the States around moving towards payment innovation. Germany has put in place a risk-adjusted scheme at the individual level, so that it takes away the risk that is right now only considered at the CCG level here in the UK. Or you can think about how you change the hospital reimbursement system so that you create capitated budgets, and accountable care organizations should monitor be doing that. At the local health economy, people can come together, multiple payers, multiple providers, to try to put these systems in place. In California, Sacramento is probably one of the best examples in the US. In Germany, Bundesknappschaft. One of the most aggressive ones here in the UK is NHS Northwest London. On the commissioning side, you can change payment reimbursement mechanisms, and Bill will talk about Arkansas, and I think Stefan will talk a bit about Germany. On the provider side, providers could seek to become accountable providers that take risk, just like we heard about for Long Island Jewish. Should FTs be doing that here? So just to sum up, I think that payment innovation is a really powerful way to align the incentives. It also allows supporting the key interventions that can deliver better care. There are multiple examples of how people have put it in place. We think there's good evidence for it, but it is not a silver bullet, and we need to do a multiple set of things. But I think it's high time we be thinking about how we take this forward seriously in the UK.
Good morning, everybody. Thank you for letting me visit you. A couple of opening thoughts here. Fee-for-service systems in the States and probably elsewhere, it has a problem that it pays for events and volume, and that's about it. Every time you have a service, you get paid. You got paid regardless of whether you did a good job, a mediocre job, or even a bad job. You got paid the same. It encouraged silos, and increasingly in our country, if you do your service, the patient leaves your office, you don't have a lot of motivation necessarily to integrate what happens to the patient afterwards. It has a problem in that in my life as a primary care doctor, if the patient isn't in the office looking at me, I cannot bill for a service. So email, phone calls, coordination of care between visits, reinforcement of messages doesn't happen, because otherwise you wouldn't have a business. So that's the bad parts about fee-for-service, the way it is now. And then on top of that, in our country and in many places of the world, the elasticity of absorbing the costs is gone. We can no longer continue to raise taxes, co-pays to patients, or premiums to insurance companies to continue chasing the rising costs. It's just we're losing that we're hitting a ceiling. So we have to manage things differently. So it gives an opportunity, because of that challenge of the cost-revenue imbalance, to begin to say, okay, how do we change the incentives of how we pay in order then to foster a more coherent way of delivering care? And our previous speaker, Mike Dowling, talked about how he builds a team. So he basically has been hiring the team and creating the team to manage that challenge. In a state like Arkansas, we have to work with the team we have. We have a state, it's a rural state, we have 3 million people. It is very rural, and there are you have to deal with the folks in the communities that are there, because that's the workforce you have. It's not something you've hired. This is the workforce that has evolved over time. So having met that challenge, our governor said, look, we don't want to do what a lot of folks do when we run into problems with costs and need and just slash benefits or slash reimbursements. Let's talk about changing the incentives and move away from fee-for-service to more of an outcomes-based approach. And we actually began to work on this for the last 2 years, and actually broke it down into the categories of we can focus on acute and post-acute care, so surgeries, acute hospitalizations, pre and post care. Chronic disease management, that's like more or less the primary care medical home, what happens on a day-to-day basis in the outpatient side, managing prevention, managing doing disease management, chronic care management. And then finally, supportive care. How do you help folks who need assistance to be in the community setting? The people with developmental disabilities, long-term care needs. Is it just nursing home care, or is it how do you keep the frail in their home environments for as long as possible? So we began to look at the metrics and the data behind this. So on things like supportive care, how can you measure what someone actually needs and then match up their needs to the services available and hold people accountable for that? And we could talk about some others as well. But on the acute and post-acute care, so we started thinking about, okay, how do we change the payment incentives? And the first notion that came up was a bundled payment. Pay somebody, X thousands of dollars and say, here, go organize your colleagues and get it done. And in our state, that was a totally rejected off the top. And the reason is because we weren't organized for that. Unlike an integrated care system like you just heard about, where everybody's on the same team, there were people in our state were not legally organized to take on that kind of risk together. So doctors and hospitals didn't trust each other. Doctors. You can imagine if we wanted to have a surgeon, a pathologist, and a radiologist in a room to share the fee. That sounds like a bad joke, doesn't it? It's just, so anyway, and then the medical society said they don't want any part of that either because they would have to be the referee. So that wasn't going to work. So what we have done instead, and actually it was very fortuitous how it's all worked out, we said, okay, fine, we're going to make people accountable. We're going to have an accountable provider who will be accountable for all the costs of an episode. And what we have launched, and we said we'll launch it by July of 12, and we indeed got 6 episodes going. We're saying, okay, everything will work just the way it does now. Patients will come in, patients will get seen, bills will be generated, people will get paid. So you have a total hip, you get your pre-op studies, you have your surgery, the surgeon gets paid, the anesthesiologist gets paid, the physical therapist gets paid, the hospital gets paid. But when it's all over and done with, we're going to say that the orthopedic surgeon is the accountable provider, so all the costs of that episode will be attributed to him. And then we will collect those episodes over time and risk adjust them and exclude the real odd outliers and say, okay, on average, you, orthopedic surgeon number 1, you did 60 cases. This is your average cost per case. And we'll just see how you do. And what we are doing is we get curves like this. And what you have on this curve here is more or less each of these vertical bars is their average cost per case. So you don't have to be perfect every case. Every case doesn't have to cost the same. It's just that over time, they'll average out. But you'll see practice variation. You'll see cost variation. You'll see folks over here probably having more readmissions or longer lengths of stay or more testing, what have you. There'll be practice variation. And what we'll be telling folks now is that we're going to put a line here we'll call commendable. So maybe it's slightly below median. Median at cost is going to be slightly below. And we're going to say, okay, if you're between here and a floor, because at some point we're going to say enough's enough, we're going to gain share with you. So if the commendable level is, say, well, just for the sake of argument, say $2,000 or 2,000 pounds, and you come in 200 under that, we'll give you 100 of that. So you'll get 50% of that difference. Up to a point where there's a floor, and we'll say, okay, below that, we're not quite sure how you got below that, so we're not going to give you more, but you'll have the maximum allowable gain share. Folks on this side, in the pink or the red, those are folks that got above the acceptable line. So they're outliers. They're much more expensive, risk adjusted, whatever reason. And so we're saying to those folks, okay, you're going to owe us 50% of the total cost of care per case above that line. So if you're 500 above, on average, that line, you owe us $250. Up to a maximum of 10% of your personal revenue. Because remember, this is total cost of care. Their personal fees it can be a fraction of the total cost of care. So we're going to per payer, because we're doing this multi-payer. is to limit their risk. And we're hoping that this will drive all the curve to the right and just eventually over time. The governor encouraged the private insurance company Blue Cross to join us, so we're doing this as a private-public framework. We don't set rates, but we're setting the incentives. We're harmonizing the financial incentives to make this system make more sense. And we have been doing televideos and conferences and getting people oriented to the idea that this is a new way of doing business. And it's actually getting a lot of traction. And why is it getting traction? Because the average doctor, 80% of the provider community, and sometimes the principal accountable provider is a hospital. A lot of times it'll be a surgeon. 80% will either be revenue neutral, because they get nothing here, they just get neutral, or be gainers. And there's only about 15 or 20% that'll be at risk. And most folks, medical societies and others, are not going to go out of their way to defend major outliers of performance. So, and actually, it's turning out that the better clinicians see themselves here, and now they have an incentive to restructure how they give care. And until they had a new incentive, they really had no incentive to really tinker with the system. They were going to get paid their fee, and the rest of it was somebody else's, they didn't have any stake in the system to reinvent, redesign. And now they're suddenly thinking, well, gee, if I did it this way, or if I did it that way, or if I organized it this way. And so we're seeing creativity happening now as a result. To give you some sense also of the slide, this is an actual slide of a common cold. And this is the cost variation of a common cold. And you can see that people gave low antibiotics on the far right, had lower costs. And the people on the left were probably using lots of antibiotics, lots of brand name antibiotics, and a few chest x-rays thrown in as well. We're going to work on the medical home. So we're not going to put people at risk, but we have a great diversity because we have small practices in some very small towns. We have great diversity in capacity. And so we have really skilled medical homes that are lean, mean. They control bed days. They control ER admissions. They control their testing style. You have to control your practice style, the patient adherence, and then the behavior and billings of your colleagues and referral agents. And if you know how to do that, or you're really selective in your referrals, and you're really selective in who you pick to be your referral agents, you can start to control all that. Not easy to do. So we're going to have a program where we're going to give folks the most benefit here if they're already here. And as they slide down that curve, they get increasing bonuses in terms of beating trend against cost increases. And if you're stuck up here, we're going to give you increase per member per month for care management, but we're not going to give you extra bonuses. But this system, beside giving folks dollars for care management, will also give people more dollars for being effective primary care. So now you're being paid because you're good and because you're managing resources. And by doing so, these folks are actually going to get maybe 130, 140% what they get in primary care. And over time, because now primary care done well pays better, they could then potentially come into these folks' market because they're going to get paid better and then eventually supplant folks. That is hard to move aside because you would have an access problem if in certain communities if you tried to change them. So anyway, those are the kind of big picture things we're working on. There's a lot going on. It's a lot of public conferences and so forth, but we are 2 years into this. We're rolling these things along. We think there's great potential. We're seeing creative thought going on, and we're not telling people what to do. Everyone's coming up with their own frameworks. If you want to go read more, we have tons of stuff online, www.paymentinitiative.org. And thank you for listening. We'll have a chat.
First of all, I would like to thank Nuffield Trust and McKinsey for your invitation. And to start with, who we are. Rivera Salud, we've been out in the market for 15 years now. And we are an integrated healthcare provider in Spain, exclusively dedicated to manage healthcare public-private partnerships. We run health departments, which means hospitals and the primary care network working together. And we are currently present in 4 health departments in Spain, in the region of Valencia. And we are also present in the central laboratory that is delivering service to 7 public hospitals in the region of Madrid. And we understand that we have been able to develop a stable and durable relation with the public administration based on long-term agreements. And we feel that we have surpassed the traditional customer-supplier approach to become a loyal partner with the local administration. The capitation system, the capitated payment, let's focus on it as we understand it in our model in Spain. We receive, as a contractor with administration, we receive an annual sum per inhabitant within the catchment area that we serve and throughout the duration of the contract, which goes from 15 to 20 years. That fee is around 25% lower than the average public costs per citizen. And it's not my opinion. This is according to the data provided by the local government of the region of Valencia and Madrid. So we have to offer more for less. This annual fee rises in successive years in line with the public health budget increase. And in return, we run the health department and we must offer universal access to our wide range of services to everyone. Also, with this annual fee, we have to cover all the operational expenses to provide the service, including amortizations, investment plans, the payroll, etc. What is not included in the contract is the primary care pharmaceutical prescription, prosthesis, oxygen therapy, and medical transportation services. These services are directly paid by the administration. Can I go back to the prior slide, please? Thank you. In a PPP scheme with a capitated system, we understand that public control must be guaranteed at all times and at all levels. In our particular case, we have the figure of the commissioner to the public government working within the hospital. As you are all familiar with already, the capitated model is focused on financing people's health, not financing activity. Therefore, disease prevention and health promotion are a must for us. In addition, with the formula that money follows the citizen, and accordingly to patients' right of access to the hospital of their choice, we have to cover 100% treatment costs of our patients who go to another hospital to receive treatment. On the other hand, we will invoice the local government around 80 or 85% of health services that we provide to patients coming from different catchment areas to our hospitals. Please bear in mind that we can only offer scheduled attention to patients from other areas under the strict control and under permission of the commissioner. Therefore, we must capitalize on quality and patients' loyalty. And I would like to point out now that with this capitated system that we have, we think that with an actual risk transfer, the alignment between the interests of the local government with those of the public, of the private company, really occurs. And to finish with, this is our integrated healthcare model, which is based on the idea of primary care and hospital working together. The hospital is no longer in the center. So it's one more actor within the network. And to successfully implement this integration model, we basically rely on what we call the triangle for success, where we find the clinical management with a strong professionals' commitment in decision-making processes. So we are able to answer to our patients' needs by doing the right thing at the right moment, in the right place, but by the right person, and of course, at the right cost. We also have implemented a modern human resource approach, introducing flexible incentive schemes based on KPIs, which are designed in line with the company's strategic goals and also with the annual budget, management of demand, and doing only what is needed. So these variable benefits for professionals range from 20 to 30% on top of their salaries. And on the basis of this triangle, we have powerful, reliable information technologies, information systems to support cross-organizational information exchange and care coordination. We like to talk about system interoperability, and we have developed our own proprietary electronic clinical record that has made it possible for us to shift from a scenario of separate work, hospital and primary care, to a new scene of teamwork where all the information is shared between hospital and primary care. Thank you.
Also from my side, first of all, thank you very much for allowing me to share a little bit of the experience the German healthcare system has had in driving reforms of financing and reimbursement. Whereas the UK and the US have decided to do a big reform every maybe 20 years, 30 years, I'm not exactly sure. We basically do healthcare reform every 2 years. So every 2 years we do a reform, and that gives us, of course, the opportunity to experiment a lot. And whenever we do that reform, we are not careful, but we do it immediately for 80 million people because everybody is part of our national health system, so to say. So over the last couple of years, here's what basically has happened. Along 4 major elements, the risk equalization between our payers. Keep in mind we had about 300 independent payers at the start of that decade. Chronic care treatment, outpatient tariff management, and hospital reimbursement. Before 2004, the fund distribution within the system basically was based on a simple formula based on age and gender. And that triggered a massive issue because it triggered a proper unfair fund allocation and a massive risk selection of healthy patients versus morbid patients. Chronic care was not specially incentivized nor funded, which again leads to more risk selections towards healthy individuals and to limited spend on chronic care. Chronic care was considered to be only a cost and nothing else. Outpatient tariffs, well, we have heard about fee-for-service. We went into that same trap. We experienced that. It was a big rat race. We had even more of a system where people did not get paid in money for their services, but it was points. And as we had a restricted budget for the outpatient side, of course, the more points you generate, the lower the value per point. And therefore, the more points you want to get. So over years and years, we had huge volumes increases and a slight and a very strong deterioration of the value per point. In hospitals, we decided a smart system. We pay per day. Of course, that allowed us to have amongst the longest lengths of stay globally. When we started to reform this and we went into DRGs, which was the natural choice, we had about 11 days on average. So whenever you went to hospital, you could basically book almost 2 weeks off because otherwise it would not make sense. So what have we done? I think it's a couple of very, very, very good things. On the right-hand side, upper side, we went all the way from the age and gender risk equalization to a full morbidity adjusted system. 300 diagnosis group, 19 disease hierarchies, prospective modeling based on multiple linear regressions, leading to redistributions of billions of euros of fund between the payers and ultimately exiting of about 150 payers out of the system because they were inefficient and previously overfunded. On chronic care, we introduced disease management program as a mandatory offering from payers and built them in a co-aligned incentive scheme where both payers, patients, and physicians had similar incentives to subscribe patients into that system. I will show you a little bit about the outcome, preliminary outcome of that. And on outpatient, we went to a episode-based tariff where we basically did one more thing, which is we put the episodes against target cost structures for the episode. So we did not look at the reality, but we did target cost structures, i.e. how much should that cost given the activities that the physician would have to perform and the way he would utilize his offices. The introduction of the morbidity system, if you look at the correlation between allocation and cost, so basically if you want to the percentage or the percentage equivalent of an R-square correlation, the original one was about at 7. As we all know, it's not accurate. The new one that we have now in the latest evaluation is about at 25, which is pretty good. And it's not perfect by no means, but as you can understand is, there has been this massive reallocation, and now there's a full transparency. What do you get basically for every patient, because you know all the morbidity data, you know all the diagnoses, and you know the costs allocated from the fund. The enforced enrollment in the disease management programs, and we basically have one for COPD, one for chronic heart failure, one for type 1, type 2 diabetes, and one for breast cancer, basically brought until 2009 about 6 million people into that system. I think today it's closer to 8 million. 8 million chronically ill people under controlled disease management has been quite beneficial for the system, because not only did the activities and quality activities go up, more frequent checking of the food, fewer cases of food problems, the rate of minor and major amputation of food linked to type 2 diabetes went down by more than 50%. But also, patient satisfaction with the treatment went up, and believe it or not, the cost went down. It sounds like a little miracle, but this is the official review of the disease management programs. And as you can see, of course, the major reduction of cost comes from inpatient care, as you would expect. So that very simple system at the end of the day. Can you go back 3 pages, 2 pages, one more? Thank you. Last not least, what I told you about the outpatient tariff. So this is more or less the formula how the tariff is being calculated. We have 2 parts of each value per episode. One is the value of the infrastructure use and the value of the physician time. And the physician time is calculated for an annual target income, an annual working time, and the time needed per episode. And the cost for the office utilization is basically driven by a cost center type of cost metrics that basically determines what the target cost should be. For that value per episode, we have now a fixed value per point, and that basically broke the trend of increasing volumes and reduced and kept the volumes quite stable. And it allowed to also reflect cost increases, morbidity increases in the reimbursement of physicians, which has ever since then been going up, whereas in the previous periods it was going down. So some impressions of about 6 or 7 healthcare reforms and over the last 12 years. We'll be curious to see what we do in the next 4 to 5 years, what other great ideas we might have in order to change this. Thank you.
Well, thanks to all of you. We have about 10 minutes left in this session, so what I'd like to do is just quickly summarize some key points and then have a bit of discussion, then we'll open it up to questions from all of you. So I think the big takeaway from all of this is that payment reform, first of all, is not a destination, it's a journey. Because when whether it's in the case of the UK or the case of Arkansas or Germany or what have you, it's constantly putting in place some new features and then adapting them over time as they do or do not work. So we heard from Ben, in our case in the US, capitation, episode bundles, pay for performance, all of this is being tried and we're refining it over time. Bill, you laid out for us the transition underway in Arkansas. We know that Ribera is fully at capitation, and then we heard the multiple ongoing continuous reforms underway in Germany. So let me just ask one or a couple of clarifying questions first so we make sure we understand these models. Bill, as I understand it, people are not actually being paid yet in Arkansas under Medicaid as an accountable provider, correct? It's not, you're designating them, but you're not exactly sending them the check yet and saying you're responsible for this and you get to divide it up.
Actually, they are now in some of the episodes in the zone where they're being held accountable, but it's over a year's period of time. So the year is ongoing. They're getting report cards. They know where they are. They've had their previous data given to them in a warning. So yes, this coming July, there will be checks and there will be accounting about where their total costs were.
And it will be the checks, there will be the gains.
The gains will be paid in the following quarter, and if anybody was at risk, that'll be deducted out of future earnings.
So up until this point, they've been getting standard fee-for-service Medicaid payment.
They're still getting standard fee payments. We're now accumulating data to look at total cost of care retrospectively. The system works just as it is now. No one's business operations are changing. There'll just be extra bonuses or no bonuses or risk at the end of the year after years of experience and their total sum of episodes of care.
Okay. And another question. In the United States, of course, Medicaid is notoriously low payer,
Right.
poor payer. You said this is it's a multi-payer system where the private pay is coming on top. Is there differential payment?
Well, the Federal Trade Commission wouldn't let us set rates
Right.
across the board. We don't talk about that. The Blue Cross plan, the private plans are doing this system with their own payment structure. We continue paying the way we're paying. We have bonuses, but the Blue Cross plan will do the same as well. They're finding it very useful because they're having problems in terms of raising premiums. So it's a way, again, of just changing the incentives and altering provider behavior.
So on the Medicaid side, just again to stay on this for another minute, the payment differential is probably going to be pretty small, yes?
Total costs will be different, but you can have substantial variation across providers. Mental health particularly, are a payment for ADHD in terms of the mental health providers per episode over a year. The differences are enormous, like eightfold sometimes. So there are certain episodes where the practice variation, total cost of care differences are huge.
I guess just to make it clear, it sounds like the difference in the gain payments that the doctors are going to get paid as a share of Medicaid payment, that's going to be a pretty small number of dollars, isn't it?
Well, actually, though, no. I mean, if you, in some of these episodes, like for surgery, it could be, if they do it well, 10 to 30% extra beyond the fee that they got for the operation.
Okay.
So that's not inconsequential.
Okay. All right. Well, with that, I want to step away from payment for a moment and ask you all a question about culture. Because in a lot of the experiments that we're undertaking in the U.S., this sounds like an exception, but some of the payment differentials are pretty small. How much of the change that we need to undertake in the way healthcare is delivered, the focus on quality and safety, the focus on patient-centeredness, how much of this do you think is really much more about changing the culture as opposed to changing the payment? Ben?
There's no question that's a fundamental part of it. We need people to practice in a different way and work as part of a team and focus on total cost, not maximizing revenue. I think that the reason why you also need the payment innovations, you need the resources to be able to go alongside it and make these things permanent. So it's a both and, it is fundamentally important.
Stefan, what would you say in the case of the German physicians?
say-
Who emerge in the Commonwealth Fund surveys as some of the grumpiest people on earth, I might add. But
Yeah, because if they have to undergo this reform every 2 years, you can understand that's not particularly happy in new systems and new learning. But at the end of the day, I think over the last couple of years, they ultimately felt that they are amongst the winners because funding for them has substantially been increased. Administrative burden has come down quite a bit. Their offices are less full than they used to be because they don't need to drive that much of a volume. So I think they're starting to understand that this was good for them, even though at the very beginning they felt it was more like torture. But right now I would say they adjust to it and they get more and more familiar with the systems. And also along that path, the collaboration between them and the payers have substantially increased. Right? So it's now very normal that payers and their physicians, they talk together, they visit each other. So it has become a much more sustainable system.
So would you say the culture has changed?
That's a big work. I think it's the attitude has probably changed first, and maybe in a couple of years down the road we will see more of that. But for sure it is different than maybe 10 years ago when they were quite hostile.
So what would you say, Santiago, in the case of
In the case
Spanish
of Spain,
physicians?
depends. It depends on the region of Spain you're looking at. So as you know, authority in health is in hands of the regional governments in Spain. And for the case of Valencia, these health departments under one single manager, general manager for the entire department, has been running for 10 years now. So I think that the cultural shift from hospital and primary care separately to working together is evolving. I would like to say the same for the rest of the country, but I am very familiar with. And we understand that it makes, from the management perspective, when we first opened the first hospital, the first PPP hospital in Spain, the Hospital de la Ribera, we were in charge only of the hospital itself, not the primary care. And after 3-4 years, we were awarded with a new contract, including the primary care. I mean, it makes a big, big difference. I mean, it has very little to do just running the hospital or thinking of a health department as a whole. So definitely, it's a cultural shift that it's needed to be undergone.